Hello and a very good evening to all the wonderful people who have joined today. This is your host, Dr. Ifrah Shakeel, warmly welcoming you all to today's webinar. Well, I would like to extend a warm welcome to Dr. Elangovan for coming on board with us. Thank you, Doctor, for joining as a guest speaker for today's webinar. Well, today's topic is implant placement and temporization in aesthetic zone. So basically, immediate placement and temporization in the aesthetic zone involves placing a dental implant right after tooth extraction, followed by a temporary restoration to maintain both function and appearance during healing. So this technique helps preserve the natural contours of the surrounding bone and soft tissue, preventing aesthetic issues and ensuring a more predictable outcome. So it is especially beneficial in the aesthetic zone where the appearance of the gums and teeth is crucial. So by combining immediate placement with temporization, this approach reduces treatment time while offering functional and aesthetic advantages to the patients. So a little about Quickdent. Quickdent is home to the most cutting-edge dental implant systems, which are of premium quality with high osseointegrative property and innovative design. Their vision is to create a sustainable range of dental implants catering to varied jaw conditions. The USP of QuickDent is that they are graftless. And one of the prime features of our implant systems is that they are immediate loading with available two-piece and one-piece regular and basal implants. So the QuickDent implants follow the basic principle of ABC, translating to all on basal cortical immediate or delayed loading concept. So, without wasting further time, I would like to start by giving a brief introduction about Dr. Elangovan. He did his BDS from University of Peradeniya, Sri Lanka, and he completed his master's in oral implantology from University of Unicamillis, Italy. He also did diploma in oral implantology, and his special interests include immediate loading and temporization, full mouth rehabilitation, and digital impression techniques, conducting courses in basal implantology and immediate loading techniques. He has also been a speaker at Global Implant Symposium and Government Dental Surgeon Association in Sri Lanka 2024. And he was a guest lecturer at the 75th Indian Dental Conference 2025. And he's currently an Assistant Secretary of General Dental Practitioner. So, once again, I and on behalf of our entire team, welcome you to today's webinar, Doctor. And for all the participants, I may inform you that if you have any doubts or queries during the session, kindly put your questions in the Q&A box so that it will be addressed at the end of the session. So, over to you, Doctor.
Okay, good evening. Thank you so much for a great introduction. Shall I share my screen?
Yes, Doctor.
Okay. Okay, is it clear, no?
Yeah, Doctor.
Okay. And once again, thank you so much for all the doctors, and good evening to I'm Elangovan from Sri Lanka. Today, my topic is the immediate placement and temporization in the aesthetic zone. Okay, before delaying, we will directly go to the uh, this is what is the immediate placement. The immediate placement simply says we are placing the implant uh, immediately after the extraction or in the immediate extraction socket. Okay, now the advantage of immediate placement, the first thing is they reduce the treatment time. The time is you can reduce the visit, number of visit, because immediate placement to extract the tooth and place the implant at the same time, you can reduce the number of visit as well as the chair side time also. Then second thing is the preservation of the bone. Immediately after the extraction, the bone is start to resolve. to prevent the or minimize the bone resorption, you can place the implant and immediately you can do the temporization with the immediate placement. Okay, third thing is the main important thing is the aesthetic. Aesthetic, the especially in the anterior zone, the aesthetic zone, they are more demanding, the patient demanding more about the aesthetic concern. Okay, and now we move on to the next slide. Okay, the challenging in the immediate placement. The challenging means the in the immediate placement and temporization, we have a lot of issue. First is the insufficient bone volume. Bone volume means we are mainly consider about the quantity and quality. Both are most of the cases it compromised due to the infection, due to the trauma during the extraction of the existing tooth. Okay. And second thing is compromise aesthetic outcome. The due to the infection, bone volume is reduced and the soft tissue defect also. So the aesthetically is a little compromised in most of the cases. Okay. And second, third thing is risk of implant failure. It is mainly due to the primary stability, bone deficiency, and due to the infection also, and need for skill planning because uh, with the advanced advanced technique as a CBCT and 3D view, you can plan it, and you need a special skill to plan place the implant on the available bone area. And second thing is post-operative swelling and pain with the extraction and placing and grafting. It causes a lot of pain and swelling. But in my presentation, I will show you how to reduce the swelling and pain with our minimum technique. Okay, and the healing time, it also prolonged with the immediate loading because of the grafting and infection. And most of the cases, we need the bone graft. Okay, and now we move on to the slide directly. And in my uh, presentation, I am showing uh, I'm showing the single tooth and multiple tooth and the segmental and the full arch. I'm covering all these slides with you, and every cases I am sharing with it has the different challenges to give the immediate loading, immediate placement, and temporization. And I'm showing uh, some technique to use the immediate temporization. Okay, this is a case one. This is a patient met an accident 20 years ago, and after that, around 2 years onward, she is getting the first discharge from the to one area, and this is the 3D view of CBCT, and she lost all buccal plate as well as the distal bone. Okay, and this is the CBCT view, and there's an infection also in the 1-1 area. And see this, the CBCT sagittal view, and my plan is I am starting the drill from this point up to the nasal flow, and I have the very good nasal flow cortical bone. So my plan is according to the screen. Okay, and my this technique, temporization technique, I use the normal alginate impression before removing the existing tooth and make a immediate temporization. Okay, see this technique. I take alginate impression before removing the tooth, and nicely with my periodo, I am extracting the 2-1 without damaging the soft tissue as the existing bone, hard tissue, and remove it and nicely curate touch and clean it and see the soft tissue. And this is my Quickdent lens drill, and I engage the second flow and check it with my probe, the Quickdent probe to check the, and this is my implant active Quickdent bicortical implant. I go and engage it with the second nasal flow, and I reach more than 110, but my implant threshold it's up to 80. Okay, and we move on to the temporization. Yeah, immediate temporization for this case, I use the normal 35-degree angle stock abutment. For this case, very important thing is the stock abutment has the little bit of bulginess on the labial side. So I want to remove it because I will discuss later the features of the temporary crown or bridges uh, uh, after this slide. Okay. And what I did is I remove the cut and remove the bulge and make a retentive groove and place it in the patient mouth with the old impression with my temporary crown and bridge material, insert it and allow to set it. After that, remove it. I remove all the excess material and remove the temporary crown and graft membrane with the xenograft. This is called as a ice cream cone technique. After that, place it and nicely polish it with the composite and tighten it. This is the this I use the 3.5 into 25 millimeter Quickdent bicortical implant, and this is after 2 days post-op. Okay, this is a IOPA and this is the CBCT view. See how is engaged in the nasal flow. Is around more than 13 or 14 millimeter. My implant, it is in the purely in the good bone, and my Quickdent implant apex the smooth surface in the nasal flow. It does not cause any irritation to the soft tissue, and I nicely engage and get the very good primary stability on this case, and see how it engages in the nasal flow and immediate provisional also. Okay. Now the second case is she also had the same issue, and but she had the fracture of 1 month. I use the same technique as in the earlier. I take the impression of the existing tooth and using my uh, stock abutment and give the immediate placement and temporization. This is a CBCT view, and this is a technique I used. One second. Okay, this is a fractured part. I remove it, and with my periotum without damaging my buccal plate, and use both sides on the mesial buccal and remove the existing tooth and place my implant. This is 3.5 into 18 millimeter Quickdent implant, and see the features of my temporary I will discuss later. Okay, this is my final product, and this is a final cement retained prosthesis. And see, the first 31st of August 2024, this is after 4 months I placed the cement retained prosthesis, and this is a 14 February 2025 after 8 months follow up. And see the x-ray also, same after 4 months, after 8 months. There's no bone loss, and the soft tissue is adapted well. Okay, this is a third case. This is a case missing of uh, one tree, and she had the difficult extraction. See this profile. She had the hard tissue defect also. It is when you're smiling, it visible more, because I use the technique called palatal rolling technique to correct the hard tissue defect with my palatal rolling soft tissue technique. Okay, this is the defect. I will show it. And with my burr, I remove the keratinized tissue and place my Quickdent implant. And with my palatal rolling, I immediately take an impression and place the healing cap and send it to the laboratory. What I am interested in this case, because if I take the measurement and send it to the lab, it is not the ideal crown to the temporary implant crown to place it in the patient mouth. See this crown shape. It has the concavity and smoothness. Everything is defect. It causes a lot of infection and soft tissue, hard tissue defect in the future. So it's our dental surgeon duty to change this temporary crown into proper ideal temporary crown for my soft tissue, hard tissue, and prevent the infection. Okay, see this video. Okay, with my normal, this is a straight abutment, and with my flowable composite, I fill this all the concave area, and after that I polish it and nicely make my implant temporary with my flowable composite and cure it. I nicely cut and polish it, and I make this is my temporary crown. It has a concave and supragingival margin, and place it and check the occlusion and everything. And this is immediately after the temporization. And after 4 months, can you see the difference between the temporary crown which I received from the lab? The second picture, you can see I convert this temporary into my proper temporary implant crown. Okay, and this is the after 4 months. I remove the 1/4 also and make a zirconia crown, and see the soft tissue is nicely corrected with my palatal rolling technique, and see the temporary how the soft tissue is healed well. And this is the digital model and cement retained prosthesis, and place it and see the soft tissue, hard tissue defect, how it correct with the normal palatal rolling technique with the normal soft tissue rolling, it corrects and see the view. And this is the fourth case I am discussing with you, because this case is he is an engineer. He is a Chinese patient from he is working in the Harborview project in Colombo, and he met an accident with the galvanized metal pipe and fractured at the gum level. And this is my CBCT view. But my plan is, because I tried with your normal implant system, you can extract and place maximum or 11.5 or 13 millimeter implant, but it does not give any primary stability or for the this immediate temporization. So my view is I am starting from the cervical margin. I plan to engage in the nasal flow at the nasal spine area. See, this is my plan. See how I aim this case. Okay, this is OPG view, and using the TM technique with my periotome, using both sides, mesial and distal, and see it can nicely cut and reach up to the root area. Mesial distal, gently move and remove it with my root extractor, and just pull it out without damaging the, especially the buccal plate. And it lead very minimized soft tissue and hard tissue defect. And take my lance drill and pointing towards the nasal spine, and with one drill technique I engage my active Quickdent implant with the soft tissue collar. It give nice healing around the soft tissue. And this is the technique called, we are uh, uh, giving the clockwise and little bit of anti-clockwise. We are calling as a corticalization of the cancellous bone. There is a final tightening with the implant driver. And this is my tie base. I fix it and take an X-ray and see the fitto. After that, we remove the tie base and fix with the lab analog. And this technique, I use my template. This is the template. You can get it from the Indian company. And I fix it with the lab analog. And this is the anterior template for the aesthetic zone. And with my flowable composite, I take the exact triangular shape of the soft tissue profile. And see the triangular shape, and rest of the part I build with flowable composite and nicely polished, and get the proper basement of my temporary crown. And I fix it in the patient mouth immediately after the extraction. And rest of the part we build with normal composite and cut and polish it. And see the soft tissue healing after 2.5 months, because I asked to come after 3 months, but the patient is going back to China. He came around 2.5 months, and see the soft tissue healing. My polished surface is very much helped to enhance the soft tissue growth around the implant. And see the CBCT view after 2.5 months after placing, sorry, after placing the implant. And see, there's no bone loss at all. Same amount of bone what we are in the beginning, it's same in the view. This you can see the cement retained crown. I fix it in the patient mouth. Okay, now we move on to the little bit of theory, because the principle of immediate placement and provisional, because we are mostly using the single drill concept, because the single drill concept means or one or minimum two drill to engage or to reduce the finish the osteotomy, because when you increase the drill in the immediate placement technique, you are prone to remove the bone and cause lot of stresses to the unwanted stress to the this adjacent bone. So drill the first last drill or twist drill and place the implant immediately with the active implant. And second thing is drill up to drop. This is mean you drill and go and engage the second cortex, the nasal floor or pterygoid or zygoma, because we need the very good second cortical bone stability to get the very good primary stability to give the immediate temporization. And second thing is very important, you need the active thread implant. Our Quickdent implant, I show it in the earlier slide. It has a very good acute taper, and it go and nicely engage the second cortex. And long implant to engage the bicortical, because long implant give very good BSA, bone implant context, as well as you can engage the second cortical. And sometimes we are mostly tilting the implant due to the bone deficiency. If you tilt 10 degree, you can get 1 millimeter more. And immediate splinting and rigid prosthesis to prevent the there's the micro movement between the prosthesis and the implant. And the last thing is rigid splinting and cross arch stabilization. For the full arches, we are mostly rigid splinting with the bar and get the cross arch stabilization. And we move on to the implant shape. Immediate loading implant should have some uh, feature. It should have the acute taper shape or acute apex is nicely go and engage in the nasal floor, because our normal conventional type of implant at the apex it is more than 2 or 1.8 millimeter, because you can't do any osteotomy on the nasal floor or it cause damage more. So it should have acute taper shape, and it should have super aggressive self tap cutting or tapping thread. And it has this Quickdent implant has a compressive thread on the cervical and deep groove for the sharpener effect. And grape type 5 type, what I mentioned is it gives more strength, because immediate loading we are engaging this implant in the bone is more than 120 130, because with the grade 4 titanium it may fracture. And long implant, because Quickdent has there's bicortical implant, there's a two-piece implant, maximum 25 millimeter long length. It gives good primary stability, and long length you can engage the second cortical bone. And let's move back onto the There's our case. This is the case 5. This patient has the mobility on the 3-1 and 3-2 and 4-1 and 4-2, and she is the diabetic patient also. And we planning to, she like to go for the implant, and we planning to remove all these 4 teeth and immediate temporization. And see this video and remove the all 4, and thus use the same technique. I took the alginate impression and keep it aside and remove the mobile tooth and place my Quickdent implant and fix the tie base, and using my temporary crown and bridge material, I insert it and for the immediate temporization, and remove the excess and remove my temporary bridge and remove the excess. Remove the excess and cut and polish it. I add flowable to make a nice contour shape and fix it in the patient mouth immediate, and see how is in this is these are the technique you can basically you can practice in your normal clinic, because it's not the advanced technique. Okay, now we move on to the this case 6. We move on to the segmental loading. This case, can you see this? And the second quadrant totally is out, the lost bone, and is occlusion also is defect. So we plan to go for the immediate temporization and using my drill and see it drop into the nasal flow. I place 4 implants and all 4 are engaged in the nasal flow. You can see it later on. There's a CBCT. Only one drill, one lance drill you can engage, and the implant placed and correct the angle with the multi-unit and immediately scan and send it to the lab. And lab people, they make the PMMA, polymethyl methacrylate, with the rigid metal bar. And see, I engage all the implant in the nasal flow and go and engaged. And see this angle, the 3D. Okay, I splintered with the rigid metal bar. Okay, now the final thing, this case is the full arch case. This case, I placed the implant corrected with the multi-unit. I have used his patient's existing denture for the temporization. Okay, see this view. She has the deficiency only. The zone 2 has the uh, uh, bone, and the zone 1 he has the very less bone, only the Bedrosian classification. She has only zone 1, the segmental 1. She has only the zone 1 and zone 2 very less bone, and there's second quadrant. She has the zone 1 a little and more on the zone 2. Okay, my plan is I use the technique called trans sinus placement. This is my first case. I use the trans sinus placement on the first quadrant. And see this patient and place the implant and correct it with multi-unit. I fix the tie base, sorry, not titanium cylinders and existing denture. I fix it and take it out and cut and polish it nicely and fix it with my multi-unit prosthetic screw. And this is the one side is a sinus placement, other side I place the, and see after 2 hours patient confident and smile. Okay, now the conclusion. My conclusion is the implant site. First, for the immediate placement and temporization, you need to go for the active implant system. Second thing is for your good sleep, for the this immediate loading, you engage the second cortical bone and get the good primary stability. And use the long implant as much as possible to get the good stability and good bone implant context. And very important things, your implant system should have all the prosthetic option. The Quickdent implant has the all the prosthetic option, all the range of implants, the conventional and the two-piece bicortical and one-piece and zygoma, and the prosthetic level also. It has the stroke apartment, angle apartment, multi-units, and the ankle channel and tie base and UCLA, non-engage in UCLA, engage in UCLA. It has all the range. So your selection should be, your system should have the A to Z uh, prosthetic option. It has the scan body also. And the temporary crown and bridge side, it should have you should give the screw retained implant crown or screw retained implant bridge for the temporary. And second important thing is margin of the temporary supragingival, because it allow the soft tissue to grow without any tension. It grow nicely and without any recession. And the cervical margin of the crown should be concave. And very important thing is check the occlusion properly. And I would thank all the doctors to join and to share my experience. Thank you so much. You are welcome, Sri Lanka. Anything you can WhatsApp me in my number, and you can see my uh, Instagram. Thank you so much, Quickdent Implant and the channel, ma'am.
Yeah, all right. Thank you so much, Doctor. It was a great presentation, and you gave good insights about the topic with, relevant case images and videos so that we can correlate better. So, meanwhile, I request all the participants, if you have any doubts regarding the presentation, drop in your questions in the Q&A box so that it can be answered. So, Doctor, we have a few questions.
Yes,
The
please.
first question is the 1 to 2 extent of the implant in nasal bone, would that not cause any irritation there?
Yeah. There's no irritation, nothing to worry about. You usually you see our there's Indians and Sri Lankan Asian they are put in the bankers like that in the nasal flow. It does not cause any problem at all. Okay, most of the cases I 1 or 2 millimeter inside the nasal flow, and the Quickdent implant has a very good advantage. It has a polished surface on the apex. It does not cause any irritation to the nasal of mucosa.
All right. So the second question is, they're asking, why did you use a cement retained in the second case?
Second case, because of the this aesthetic concern, I think the screw hole is sorry, screw hole is more close to the there's edge. That's why I use the second case. 1 second. This case,
Yes.
because of the there's ankle to correct the ankle because the screw hole is comes out. That's why. Because the temporary you can see it's screw hole. It's in the buckle surface.
All right. I hope that answers your question. So the next question is it necessary to engage every time to engage second cortex if we are doing all on six?
Uh, because I am more confident to place the nasal flow because when you see the literature is in the European based literature, most of the cases they are not engaging in this nasal flow because their system they are using, but the implant system they are using, they don't have any facility to engage the nasal flow or pterygoid. The most of the system they don't have it, but Quickdent have the facility. That's why we are mostly engaged in the nasal flow. Because if you have the very good stability, because before I encountered with the Quickdent, I used a normal conventional implant, 16 millimeter or 13 millimeter implant to use the tilted implant because you need a very good bone to place it and you can load it with the because if you reach the primary stability you can use it, no problem at all.
All right. The next question is, sir, according to you, which is a safe temporary material to be used? And can you tell us about the occlusal and protrusive contacts, whether to give or not to give?
And can you repeat it?
Yeah, according to you, which is a
Mm.
safe temporary material to be used?
Mm.
And the second part of the question is, can you tell us about the occlusal and protrusive contacts, whether to give or not to give?
Okay. And first thing is because I am working in Sri Lanka, not like India, because have the all the lab facilities. Because in Sri Lanka we have the very less there's access to the lab. So we are very strict to the chair side temporary. Most of the time I'm using the composite or the composite based material like a pro tem or temporary crown and bridge material because it's more no, you can polish it well and fix it. It does not cause any irritation. And I am really a little bit of reluctant about the acrylic because sometimes if uh, get the acrylic crown, I trim it, I put some composite material, nicely polish it and place it. So my more preference is the composite based material, resin based material. And second thing is, and nowadays I am using this bio HIPG also. It's very good material, but you can give it as a permanent because it's expensive. And the occlusal side, always I am keeping without conduct any movement, any protrusive or centric eccentric position without touching because because we can't believe our patient because they are giving lot of promises to us but they go and eat they are biting whatever it is in the because I am advising don't bite anything around 3 months, take care of very rare very the patient is especially in the Asian country people.
All right.
Anything? Okay.
The next question is, sir, in your case where you give PMMA temporary, after how
Yeah.
many months will you change
No, no,
into
no.
a final
Immediately,
prosthesis?
immediate. I saw it. No, this case. I immediately scan and send it to the lab. Within 4 or 5 days, I fix it
Okay.
because you can. Oh, sorry, 1 second. And this case, you can immediately scan and send it to the lab. Immediate scan. 1 second. Can you see that? Immediate scan and send it to the lab. Same day.
All right.
Okay.
The next question is the final processes also follow the temporary shape or can we modify it?
That depend on the patient wish because in this case also I planned to go for the there's a defect on this shade and there is a decision up to the doctors and the patient, and most of the time we are giving the temporary to get the rough idea about the final prosthesis, so you can get some gain or get some idea from the temporary, and anyway you discuss with your patient and get the final conclusion.
All right. The next question is, can we engage the floor of the sinus for bicortical
No,
engagement and immediate
no.
loading?
No, because usually I'm not disturbing the this sinus flow because the Quickden has the very sharp apex. It go and pierce the sinus flow, and sinus flow the especially it has a very thin cortical bone. Usually, I am doing with the 1 or 2 millimeter engagement with the normal quick and conventional implant without lifting. Just with the active implant, just push it 1 or 2 millimeter and leave it without loading. So I am not advising to engage the sinus flow because very thin cortical bone and it has lot of risk for the infection and those
All right.
sinus infection. Okay, because I
The
don't
next
have the
question.
much idea about that. That's why.
Okay. The next question is how to maintain the patency of access hole while fabricating the temporary.
Pardon, I couldn't.
How to maintain the patency of access hole while fabricating the temporary.
This access hole, just drill it and just put the plumper tape and close it and insert the material. After that, drill it and take it out with the, and after that, you nicely close with the composite and polish it.
All right. The next question is which implant material is most commonly used in patients?
Implant?
Material.
No, I couldn't get it. Implant
Which
material means?
implant material is most commonly used in patients? Material. It's
Material.
basically titanium
Yes,
implants.
basic titanium. No, I am not
Yeah.
any other material. I am not using only the titanium.
Yes. Okay, the next question is how to seal the access in temporary crown and screw retained.
Screw retain with the composite, usually composite.
Okay. The
No
next
other.
question is zirconia or titanium, which is used in patients. That's been already answered. It's titanium.
Okay, titanium. No, I don't.
Next,
I am not using any rather only titanium because zirconia type of implant is now they introducing because I don't have any experience.
all right. The next question is which bone graft you prefer to use in buccal wall defect?
Uh, because mostly because we don't have any access for the this natural bone, because natural bone you can harvest from the other area, but patient they are no, they don't like, because why you are go and take it from the other area to damage other there's because we are minimally invasive and place the implant for the immediate. When you elevate the graph, the bone resorption is more. So most of the time, it's available for me because there's a lot of literature for other there's a bone graft, because it is what I am using, what is available with me. I use the cellulose membrane with the xenograft.
Okay. So the next question is for the mandibular cases, which are the
Mhm.
cortical plates we need to engage?
Yeah, mostly I go and engage with there's a lower flow.
All right.
Okay.
The
Because
next,
it's a resorb case, no, go and engage with the nasal flow. If it is one thread is enough to engage, you can get the primary stability more than 110 like that.
all right. The next question is anything about single piece implants for aesthetic zones?
Because I used two cases for my there's a I'm conducting course with my Kainar and Ramesh with the Quickdent, because I used only one implant, one case for the for the demo, because only the anterior region there's I used the single piece implant. She has the is around 12 millimeter resorption. So we take it out the tooth and place the single piece implant and immediately give the temporization. That's only I place it, because I am not the man to telling about the single piece, because I'm purely two piece.
Okay. So the next question is without tearing the sinus, can we put zygomatic implants?
No, because I didn't place any zygomatic implant. I don't have any idea, please.
All right. So the next question is all cases discussed were with cortical implants mostly.
Hmm.
So the conventional implants were not recommended at all for anterior cases.
Just you can place it. There's a what you call the conventional implant, because I have the cases. I I uh, I joined with the two piece bicortical with the normal conventional. Whatever place, if it is if you don't have the room for the nasal flow engagement, place the nasal flow one or two and engage with the this other area with the normal conventional. It is okay, no issue. If you had the primary stability, definitely you can do it.
Okay. The next question is can you explain about the socket shield techniques and aesthetics?
The socket seal, I didn't have the idea, because socket seal is a very sensitive technique, because because very sensitive to very, because most of the cases is fail when you removing the socket seal to keep the very tiny plate of the cervical part of the tooth is very difficult. It's so technique sensitive, because I don't have any experience. It's a part of the parcel extracted technique. So
All
no
right.
idea.
Okay. So the next question is any minimally invasive technique for managing black triangle in anterior zone?
Mm, no, ma'am. No idea, because without any experience, I can't explain. No, please.
Okay. The next question is what is the occlusion in full arch in case of temporary prosthesis?
There's a mutually protecting occlusion we are usually keeping the full large case.
Okay. The next question is, Doctor, can you please share the OPG of your full arch case? I want to take a picture for my case.
Pardon?
They wanted you to show your OPG, the full arch case.
Full large case, 1 second. Okay. Ma'am?
Yeah, I hope this is visible. So the next question is, what instruments are to use for curettage of anterior lesion since instrument accessibility till the apex is so difficult?
No, can you repeat, please?
What instrument is used for curettage of anterior lesion since the instrument accessibility till the apex is difficult?
No, because I'm using the normal spoon type of curates. You can nicely go and remove the there's infected part. It has a very tiny one also because I bought it from India.
All right. Okay. Also, one doctor is asking, do you provide any courses like, in Kolkata or in India? Do you conduct any courses, doctor?
No, ma'am.
Okay. All
No.
right.
Because I got the chance to present my case as in 75th of Indian Dental Association. I am not conducting any courses.
Okay.
Okay.
The next question is management in anterior deep bite cases. How to plan the processes in immediate implant?
Anterior deep bite cases is very risky because of the this deep bite because very carefully handle these cases because the immediate loadings most of the cases I failed because of the deep bite
All right.
because very careful about the posterior occlusion. If you don't have any posterior occlusion, don't go for the immediate temporization or immediate loading for the anterior because very much important. I have lot of failure due to the occlusal. There's a occlusal, the improper occlusion.
Okay. The next question is, can you brief about mutually protected occlusion?
Mutually protective occlusion means when you move there's the jaw anteriorly, it protect there's what you call um, how can I explain? When you move anteriorly, it the mutually protecting occlusion means it move anteriorly. The posterior occlusion. Uh, no, I couldn't explain it. I'm sorry. Uh,
Okay. The next question is achieving closure in immediate implant cases in single molar is very difficult. So, can you give any suggestions?
No, ma'am. Now I'm not going for the this immediate placement or immediate placement. I will do it. I'm not giving any immediate loading or immediate temperature for the molars.
Okay. The next question is how to irrigate the socket in infected cases and which solution to be used.
Usually, I'm using the saline
Okay.
nicely with my piezo. It gives a lot of very good force. Go and with the curate as nicely clean and remove it. Actually, I
Okay.
don't know any solution is available, but I'm using the normal saline, cool saline.
All right. The next question is which type of permanent crown is good, PFM or zirconia against the natural teeth?
That depend on you and the patient economy and everything is decided by the this money because mostly I am going for there's screw retail PFM.
Okay. All right, doctor. I guess that's it for the questions. And
Thank
those
you.
asking about the e-certificates, if you have registered for the webinar, then you will receive the e-certificate. There's another question, doctor. Last
Mm.
question.
Yeah.
Tips for extraction in anterior cases. Usually all are RCT treated and ankylosed.
Mm. Because
So,
if because most of the cases the RCT teeter is very difficult to remove, but you can nicely, because it takes a lot of time to remove the tooth, because very difficult, and nicely remove the mesial distal part of the bone. But uh, anyway, you can with the periotom, very there is a blade like a periotom. You can nicely cut and remove there's a tooth from the this root RCT root,
all
because
right.
I didn't have any much experience about this to explain this one.
Okay. Okay, doctor. I guess that's all for the questions. So it was wonderful to have you on board with us. And
Thank you so
with this
much.
note, we'll be ending this session. And thank you to all the participants. And once again, thank you, Dr. Elangovan, for being our guest speaker today.
Thank you. You are welcome always, Sri Lanka. Anything, give me a call.
Sure, doctor. All
Okay,
right.
thank you so much, ma'am. And dear colleagues, thank you so much to listening and sharing with my cases. Thank you so much. Good
All
night.
right, doctor. Bye bye.
Okay, bye.